Hemorrhage is the leading cause of maternal death worldwide, accounting for 27% of maternal deaths globally. UK deaths from hemorrhage are now rare due to prompt recognition, improved management and timely intervention. They are, however, a common obstetric emergency. Postpartum hemorrhage, or PPH, is a blood loss of 500 millilitres occurring within 24 hours of birth, or as a secondary PPH up to day 28 postnatally.
Oh, well done, Anne. She's lovely. Well done. Just have a look down below, okay? You are bleeding a bit more than I would anticipate, so I'm just going to pull the buzzer. There are going to be some more people coming into the room, okay? They're just going to come in to help.
Alright.
Yeah, we're going to get more people in to help, okay?
The causes of the bleeding are summarised using the acronym the 4 T's.
I'm just going to put pressure on your tummy. I know that's uncomfortable, sorry. There are more people on their way.
Hi, Annie,
Nicole.
coordinator. How can I help?
Baby was born 8 minutes ago.
Okay.
Having a PPH, we're up to about 800 mils now.
Okay. I'm just going to lower the head of the bed down. Anne, is it okay for me to pass baby to Daddy? Is that okay? There we go. Daddy can have some skin to skin. There we go, Daddy.
Baby straight up, okay?
Yes, please. 4 twos. Obstetric emergency, room 10, birth centre.
I'd like to report an obstetric emergency, room 10 on the birth centre. Yes, that's correct. Thank you.
Anne, I just need to pop the oxygen onto your face. Okay, darling. Yes.
4 twos has gone out and I've got the PPH box.
Excellent. That's fine. How's the uterus? Boggy. Okay. And what's the blood loss so far?
800.
Okay. Let's do the blood pressure. Thank you, Janice, for coming to scribe for us.
Okay.
Hello, Emma, OBP. Hello, Joe Gordon, consultant anaesthetist. Hi, Joe. We're having a PPH, currently 800 ml loss. If you're able to get some IV access and maintain the airway and the breathing for us, if you could just confirm to me when the bloods have been taken. Sure. Thank you very much. Okay. Thank you. I'm going to go and get some more medication for you. Have we had the
Squeeze your arm. She has the spectrum prior to the centre.
Okay.
Just come in and
get
call
some
to
medicine.
Well done, Anne. Just keep your breathing.
Sorry, Anne.
You're fine. We're all here to help.
We give the metron there.
40 units.
40 units is in.
Blood pressure's 110/80.
Thank you.
An average fit, healthy woman can withstand losing a significant proportion of her circulating volume before she shows any signs of compromise. Early recognition and management by the MDT will help prevent severe deterioration of the patient. More than half of the women who died of hemorrhage between 2009 and 2012 weighed less than 60 kilograms. Smaller women have a lower blood volume and therefore their ability to tolerate blood loss is reduced. Frequent stop moments will help keep the team maintain situational awareness and deliver appropriate resuscitation to the mother's circulation.
First dose of ergometrin being given.
That's great.
Ensure appropriate blood samples are taken promptly and labelled accurately to avoid delays in treatment.
Leash, consultant obstetrician. Let's review the situation. Annie?
So I had a PPH, we're up to about 1.2 litres now, Leash.
Okay, I'll get the checklist.
Thank you.
So I've taken those bloods, Nicole. I've taken full blood count, group and save, coag and Usanese. I'm going to get a second check.
Lovely.
We'll send those off urgently.
That's great. Are you okay to send those for us, Emma?
Yes,
Thank you very much.
The second large IV cannula is in, and
Litre
we're just
Hartmann's
connecting
to commence.
2 litres of IV Hartmann's to go through immediately.
Women die from hypervolemia rather than anemia during an acute hemorrhage, therefore initial fluid replacement is a priority. Weighing blood loss and monitoring the cumulative measured blood loss will help to guide fluid resuscitation.
Would you like a catheter put into
Yes, can we have the catheter in, please? So let's review the situation. We've got a major PPH at the moment, 1.2. Airway, Emma?
Airway, patient voice alert, 50
Breathing.
litres, 50 litres of oxygen now.
Respiratory rate?
14.
Excellent. And circulation, Joe? Are you happy with what access we have?
We've got 2 IV cannula and 2 litres of Hartmann's currently running. We are requesting 4 units of red cells on the way.
Okay.
She's tachycardic at 120 beats per minute.
Okay.
She's got a non-invasive blood pressure of 90/40, so she is hypotensive.
Right.
And she has a delayed capillary refill, which we're
Okay.
treating with the fluids.
All right.
Catheters in situ and draining clear urine.
Okay, so what does the uterus feel like?
It's boggy.
It's boggy.
Yeah.
Can we do bimanual compression,
Yes, we can.
please? We've got the catheter in.
Placenta was complete.
If fundal massage isn't effective in contracting the uterus and reducing the blood loss, the internal manoeuvre bimanual compression is required.
Yeah. Medication-wise,
We're given ergometrin, transatlantic acid, 40 units of Hartmann's.
I'd like you to draw up some carboprost, but what's the ongoing loss now?
It's around 2,000 mils.
Okay, I feel we need to initiate the massive obstetric hemorrhage protocol, and we need to move to theatres.
The massive obstetric hemorrhage protocol is activated when estimated blood loss reaches 2 litres, when the patient is unstable, or when there is ongoing bleeding.
Massive obstetric hemorrhage, room 10, birth centre.
Pre-alert the teams in maternity, theatres and blood bank that an MOH is occurring.
Carboprost, and we'll
And we need to take you to theatre because you've been bleeding a lot, okay? We need to put you to sleep and we need to stop this bleeding.
Hello, blood bank.
Hello, hi, it's the SHO on the birth centre. Yes, we've activated the MOH protocol, please.
It takes some details from the patient. Could I have the patient's surname, please?
The patient's specific details must then be shared directly with blood bank to implement the MOH protocol and release blood components for transfusion.
That's perfect. This patient's got a valid group and save. So I can have pack 1 ready for you in about 5 minutes.
That's great, thank you very much.
To enable the porter to collect pack 1, they must have a blood collection form with the patient's barcoded ID sticker.
Okay everyone, should we just do a stop moment? We've got Anne Underwood, who's a gravid 4. She's had a massive PPH. We're estimating a blood loss of 2.4 litres. She's got 2 large IV cannulas. So far she's had 2 litres of crystalloid and she is currently cardiovascularly stable. We've got 2 units of red cells in transit coming from the blood bank.
Use the whiteboard to guide the team managing the ongoing MOH and document contemporaneously.
Thank you.
Blood components must initially be checked away from the patient's bedside using the patient's documentation to ensure the correct blood product has been received. Units should then be checked by 2 members of trained staff away from the patient prior to the bedside check.
We've got 2 units.
2 units of red blood cells.
So we're going to check the blood. We've got Anne Underwood.
Yes.
Anne Underwood. Date of birth 02/12/1986.
Yes.
02/12/1986. We've got G number 40000011.
Yes.
40000011. And then we've got a donation number. We've got G095619164169Y.
Yes.
It expires on the...
Blood products should be given early and should be warmed. Transfusion of red blood cells aims to restore the oxygen carrying capacity. Other blood products should be used to correct coagulation defects. Where the clinicians in theatre suspect DIC, this should be communicated with blood bank and the on-call consultant haematologist so that further supports can be offered.
Hello, it's Joanna Gordon, consultant anaesthetist. Yes. Have we got ongoing bleeding, Leash?
Yes, we do. I'm still not got the Bactrian yet.
Okay. Can we confirm, team, that we want pack 2, which contains 2 units of red cells and 4 units of FFP?
Yes, please.
Yes, please. We'll have pack 2, please. Thank you. So let's just reassess the situation. We've had 4 units of red cells.
Significant hemorrhage may need further transfusion requirements and closer observation in a high dependency environment. Decision to admit to critical care should be made by the multidisciplinary team following further clinical assessment.
Hello, this is Dr. Gordon, consultant anaesthetist. I'm just ringing to confirm that we're standing down the massive obstetric hemorrhage protocol for Anne Underwood. Yes, that's right, standing it down. Thank you. Bye.
The management of hemorrhage following birth requires effective communication and leadership from the MDT to initiate a series of medical and surgical interventions. The complexity of the teamwork is further stretched as the patient may move clinical areas and involve teams within blood bank and theatres. In summary, early recognition of the accurate blood loss and clinical assessment of the woman allows for early treatment to arrest the bleeding and resuscitate the mother. As always, the team should document caregiving, debrief the team and family, and report via Datix.